Hi, my name's Eileen Irvin. I'm here from Ipsos Mori with my colleague Tamitha Webster from the Care Quality Commission, and we're here to talk to you today about the Adult Inpatient Survey pilot, which we did in 2019-20, looking at moving a postal survey over to a push-to-web design. So as we go through today, we'll talk about what the pilot was and what impact that move had on response rates, demographics, and trends, and then talk a little bit about what the next steps are. But firstly, I'll hand over to Tamitha to introduce you to the NHS Patient Survey Programme.
Thank you, Eileen. So yes, I'm just here to say a few words on behalf of the Care Quality Commission and also to tell you a little bit about the NHS Patient Survey Programme. So the Care Quality Commission is the regulator for health and social care in England, and the Care Quality Commission owns the NHS Patient Survey Programme, which asks for patients' feedback of their experiences of NHS care, and we do this at the level of every hospital trust in the country. So CQC uses that data to support its regulation and inspection activities, and data is also used by other NHS partners to help to assess and improve the quality of patients' experiences of their care. We have 5 surveys within the programme. You can see those listed on the slide. Those surveys that are highlighted in purple are run on an annual basis, and the 2 surveys that are highlighted in pink are run once every 2 years. So the programme has been running since 2002, and it has been predominantly paper-based since its inception. We have used some telephone surveys previously, and we also did some experiments using concurrent postal and online delivery. But it's fair to say that we realised that we needed to keep pace with the changes that are taking place across the survey industry, and to really start to explore what the opportunities for exploring digital delivery might be for the programme. And this really coincided with the strategic direction that CQC has been taking more recently, which is starting to look at how we can become a more intelligence-driven organisation. So that's really how we increase the use of data to improve our approach to regulation, and also how we support improvements in the efficiency and effectiveness of the regulatory activities we undertake. So that was really the push for us to start to think about how we explore online first methods. And to take us forward with this work, in 2018, we started working with Ipsos Mori so that they could set out a plan for how we start to test and reshape the way that we deliver all of the 5 surveys across the programme. So Eileen will now talk us through the results of the first of those pilots for the adult inpatient survey.
Yeah. So to start with, what was the pilot? So the aim of the pilot was to determine the feasibility of moving to sequential push to web. So sending initially letters that only encouraged people to go online, and then later sending paper questionnaires once they were further into field work. Push to web has 4 main potential benefits over postal only that people talk about. One is cost effectiveness. You don't have as much postage costs, and you save on scanning, things like that. Better data quality because you can introduce your validation rules, increasing responses from younger participants, and there's an argument it's more environmentally friendly if you're using less paper and less printing. But it also has 4 major risks. Whenever you make a change to methods, you can always impact your trends, an impact on non-response bias. People who go online tend to be better educated, more well off, those kind of things. It can impact your response rates. Push to web tends to have a lower response rate. And that can therefore lead to a negative impact on costs, because you're having to send out more reminders, particularly if you've got a set number of responses you need. So the pilot tested 2 alternative push-to-web methodologies. So the control, as it had always been, was a letter with a paper questionnaire, followed by a letter a couple of weeks later, and then a letter with a paper questionnaire again in week 4. So 2 paper questionnaires and 3 mailings. As it was a named sample with mobile numbers, for the experiments, we tested a letter with just a URL, followed by an SMS 3 days later, then a letter with a URL at the beginning of week 2 with an SMS 3 days later. Then week 4, you get the first letter with the paper questionnaire. And then for experiment group 1, that was followed by a letter with the URL only, an SMS 3 days later, and experiment group 2 got an additional paper questionnaire. So to do that, we updated the materials. So you can see the invitation letter for the control group and the experiment group here. And for the experiment group, we made sure to put the login details kind of front and center with a nice big box around them, so they were very clear and visible. And for the text messages, we made sure to include a reference to the hospital that people had been to, and the term NHS survey is who the SMS came from to legitimise it. And it included a link that went directly into the survey, so they didn't need to log in. And a free phone number so people could get in touch if they wanted to ask any questions, opt out, or just confirm what the survey was about before they took part. So impacts on overall response rates. Overall, the response rates were not statistically different between the experiment and control groups, but that does include an additional contact. So we knew that we were likely to see a hit in the response rate, so we did include that additional contact in the experiment groups. So just looking at the first 3 mailings, we do see that drop of response rate of about 7 percentage points that we were making up in the 4th mailing. And when taking part, more people went online when only 1 paper questionnaire was included. So 61% in experiment group 1 who just got the 1 paper questionnaire, and 51% in experiment group 2 who got that 2nd paper questionnaire in the final mailing. The SMS reminders were particularly effective at boosting response rates. So as you can see here, those who didn't have a mobile number were more likely to take part than those who did in the control, but that swapped completely in the experiment groups. And that likely reflects the demographics of people who are likely to have a mobile number, so older people versus younger people, things like that. And we've seen in other pilots that making sure you have as many mobile numbers as possible makes those SMS reminders really effective, not just at moving people to take part in the survey, but moving them online. So moving on from that impact on demographics, actually the sample demographics were generally consistent. So having that postal mailing really did do that extra bit of work, which is particularly impressive because the inpatient survey where we started is an older population by nature. That's people who've had a hospital stay. So having them actually be willing to take part online was a really big deal, really. The demographics of the IMD, which is Index of Multiple Deprivation, was pretty consistent. So you're not seeing those wealthier households being more likely to take part now it's online. But actually it was more representative by age group. So you are seeing those increases in response rate for essentially the under 65s, particularly the 36 to 50s. That's where you see that kind of biggest jump. For experiment group 2, where you get that additional postal questionnaire at the end, we also saw quite a big increase in people from Black and ethnic minority backgrounds, which likely reflects the work that's already been done, which shows that those people from BAME groups tend to respond later in fieldwork after there have been more reminders, and it was just particularly effective among that group. But what does this mean for trends? So 11% of our unweighted answer codes showed a statistically significant difference between the control and the experiment. And that was not controlled for by weighting, and our weighting did take into account things like gender and age and the method of access and care. So experiment groups gave more negative responses to attitudinal questions across the board. So you start seeing increases in things like people saying they've got no confidence and trust in doctors or nurses who treated them. They didn't feel they were treated with respect and dignity. And as I said, that wasn't controlled for with weighting. So that does suggest that trends would be broken when moving to this mixed methods. So in terms of next steps, the 2020 survey, which we're currently in the process of getting into field, is using that push to web methodology with 3 mailings. Further pilots have taken place on the children and young people and maternity surveys, and the maternity survey is actually also moving to mixed methods next time it runs. And more pilots are planned to test moving the community mental health and urgent emergency care surveys to push to web over the next year or so. So thank you. Any questions?